Hello, welcome to this week's HSJ Health Check Podcast. I'm Dave West, HSJ Deputy Editor, and each week we gather a cast from our team of expert journalists to explain and debate the most important news issues right now in NHS policy and leadership. This week we're going to talk a bit about a small development in healthcare that you might have heard of, namely the COVID-19 coronavirus outbreak. One of the consequences of coronavirus is that lots of people will be grappling with what it does to their other priorities. Do they slide off the agenda altogether? We won't be ignoring other things this week, and we will also be talking about controversy over A&E targets and the NHS financial framework. I'm joined to do this by Bureau Chiefs James Illman and Lawrence Dunhill, and by Senior Correspondent Sharon Brennan. And first off, Sharon, on coronavirus. We're speaking right now on Thursday afternoon, and obviously this is a fast-changing picture for listeners. But could you give us the a rough appraisal as it stands now of how coronavirus is looking in terms of the impact that it will have on the NHS?
So the CMO, Chris Whitty, who is now becoming probably one of the most recognised faces of a CMO for years, spoke to the Health and Select Committee this morning. And for the first time, I think he gave us an idea of the timeline that the NHS is looking at, having to deal with some of this stuff. So although they don't know when the peak hits, he's thinking that roughly 50% of cases will hit over a 3-week period, and about 95% of cases over a 9-week period. So then he was talking about how the NHS manages those pressures. He's been talking a lot about flexibility and trying to move stuff that can be moved to before or after the peak. Obviously, what he didn't say was that obviously depends on having to have very good modelling. And if that modelling doesn't work out and the peak extends, plans might therefore, that are being made as we speak, might therefore not work out. What he was clear on, what we do know, is that they are now also considering asking final year medical students to be drafted into hospitals, and also first-year doctors to have their responsibilities extended so they can also help. And I think that's in addition to what was called the Dad's Army last week about trying to bring in retired doctors. He didn't comment whether or not that was because retired doctors aren't actually that keen on coming in, and more ultimately would also be in the kind of the at-risk category of being over 60 in the first place, which they believe the virus hits more severely. Other than that, I think he also highlighted something that was quite scary, that he thinks children's services will be mostly protected, which is good news. Adult services, he said, could at some point overtopple what the NHS is, could potentially be overtoppled by what the NHS can cope with if the top case scenario of which he's been working out actually comes to be true. And he said some of the biggest pressures could be felt on those that depend on oxygen or need ICU beds. And obviously they are the areas where you can't mitigate, you can't flex.
It's quite hard to expand.
You can't expand the ICU. It's very hard to get staff that's skilled enough to do that, and also you can't flex before or after the crisis. So reading between the lines, they're working to try something out to work out how best to deal with it, but it's going to be a tough ask for the NHS to cope during those peaks.
How much of an impact do you think it's having on? Do we have an idea how much of an impact it's having on the NHS already, if at all?
I spoke to one CCG leader this week, and he said, as far as the coronavirus is, the planning guidance is out the window in terms of being able to stick to it. Anything could happen. There was an interesting part that I've been following up that will be out as a story soon about how CCGs were asked in February, this is just one example, of having to cope with any drug price surges in the future within their own allocations. And if that stands, then any drug price increases we could see as a result of, say, China's factories not working, or the recent news that India is no longer exporting some of its pharmaceutical products. So any drug price surges as a result of that could then be left for the CCGs to handle. So, I mean, that's a small case, but I think that shows how wide-reaching these financial concerns could be.
Likely to. Yeah, someone I was speaking to earlier said that ambulance trusts also already notching up costs. They expect to be pretty substantial by the end of this March, say before anything's actually hit in a big way. So clearly costs and the ability to be clear about how and where the funding's going to come from, which I don't think is the case at the moment.
I also think linked to the ambulance service is the issue around NHS 111. They've seen a surge in demand this week, but they've been trying to answer more calls, but haven't been able to answer all of them. So I think about 400,000 came in last week. They managed to answer 340,000. if there isn't more capacity brought into that line, you could then suggest that A&E is going to start becoming overwhelmed, because ultimately that is meant to be the one thing that kind of deters people from going. And if they can't get an answer that way and they're worried, you could see that spill into A&E potentially. So again, costs around, do you increase the numbers on NHS 111, and can you do that safely, knowing that they have the understanding of what advice to give to people who are calling?
Okay, James, have you seen anything in the performance? Obviously the winter performance figures are still running, and while we haven't seen any huge acute demand so far, have you seen anything around the impact of coronavirus so far on things like 111?
I'm sure we're going to, on 111, as Sharon was saying. I mean, it's sort of unprecedented levels of pressure now. So they had 340,702 calls last week. That's 22,000 more than the previous week, and over 51,000 more than the same week last year. And that's just not really sustainable. And as Sharon rightly says, that's going to have a wider impact. Performance targets. Performance of the NHS is already really, really struggling. So, this is no doubt going to make the figures even worse.
Yeah, I noticed. I think Chris Whitty used the wording this morning that during a peak, if as is quite likely, we get to a peak of coronavirus demand, it could be anywhere. Impact could feel anywhere like a very bad winter to something a lot more excessive than a very bad winter. I guess if we remember back to last summer, actually the NHS was already experiencing pressure during winter, during summer, which was like a quite bad winter. So you in fact maybe kind of compounding a winter on top of a winter.
Completely.
Okay, well, clearly it's going to be consuming huge amount of focus of NHS leadership over the next few weeks and months, and we'll talk about coronavirus again on the podcast. But it is interesting as well, and crucial for the jobs of a lot of leaders in the health sector, how it interacts with other priorities. And one of the other big milestones we're expecting this month, in addition to the budget, is the outcome of the NHS England clinical review of standards, in particular a decision about the future of the totemic 4-hour A&E standard. And James, could you give us an update of where we are on that review?
Yeah, sure. So this week's been a pretty crucial week in that debate. Just broadly, the recommendations for urgent and emergency care and for cancer targets are expected in a report by the review later on this month. And this week, the Royal College of Emergency Medicine and NHS providers both came out and signalled that they were open to dropping the 4-hour target. They're two pretty pivotal voices in the debate. We've already had the sort of Health Watch England signal that they are supportive. Matt Hancock, the health secretary, he's very supportive. So all the kind of key players in the debate, other royal colleges, sort of the big beasts like the Royal College of Physicians, they're supportive as well. Now, that's not to say that there aren't a lot of sceptical voices around. There's certainly a lot of scepticism, both around the idea of dropping the target and also the way that the review's been carried out. But certainly it looks like there is going to be a recommendation for something to replace it. The key players seem to be swinging behind that idea. Now, what replaces it? Well, they've spoken about this basket of metrics. Now, baskets of metrics to replace the 4-hour target have been spoken about for about a decade. So there was, the national quality indicators in 2010. In 2017, NHS Improvement tried to develop what they called an A&E scorecard, which was supposed to bring in the 4-hour target with patient experience and staff experience. But anyway, they clearly didn't work because they're not here now. So the latest basket, again, we don't really know what's going to be in there. We know they've been looking at various measures, including average weight in A&E, time to assessment, shorter targets for the sickest patients they've spoken about. But my understanding as well is they want to bring in targets that represent the wider system. So they want this to be a basket of metrics that is a kind of a basket that represents system pressure, not just pressure on the A&E.
When you say system, do you mean related but things that you wouldn't characterise as emergency care, like the new community targets or access to general practice, or do you mean the wider urgent and emergency care system?
No. I mean, we could be talking about upstream. We could be talking about kind of bed occupancy targets,
so stuff that's still within the kind of hospital or emergency system.
Yeah, but also maybe ambulance and the process has been shrouded in secrecy. So the report should be very illuminating. But yeah, I mean, it doesn't sound like there's a lot of certainty around what they are, and sort of RChem and NHS providers have both sort of given conditions, spoken about devil in the detail, and said we'll only back it if X, Y, and Z. But broadly, they are signing up to a direction of travel rather than a robust plan.
And one of the things you've written about is the fact that the governments and regulators have tried in the past, over the last 10 years, to move before to kind of bundles or baskets or kind of balanced scorecard metrics for emergency care. Is there any sense of why this time they might actually succeed in moving?
I think this time there is the political will. There's the drive from. I mean, this is coming from right at the top of NHS England and improvement. Simon Stevens very keen on this. Matt Hancock has already, pretty much preempted the review and said he got a bit of a telling off from the Royal College of Emergency Medicine last month, when they were saying there was no evidence yet that there was a viable alternative. So it'd be interesting to find out what's changed in the last month for them to now sign up and think that maybe there is.
Yeah.
But yeah.
One thing that I haven't studied the history books, but one thing that I think is different is that this time they've been willing to talk, as well as you say, really importantly, this row or debate has involved Simon Stevens and the Health Secretary, so they're kind of well involved. But in the past, I think they've talked about, we're going to move from the A&E 4-hour target to a basket of measures, which includes the 4-hour A&E target, which allows it to continue and kind of always, it's very hard to get off it if it's still being measured and still there as part of this basket. Whereas this time they are very explicitly talking about that one will be scrapped,
Yeah.
So actually at some point they're going to make it difficult, though not probably impossible, to actually measure yourself against the 4-hour target.
Yeah, I think there's also a massive issue about how the new targets will be sort of. Chris Hopson, the NHS providers chief executive, talks about the need for a currency converter.
Yeah.
So here's a good turn of phrase. So that so we can join up, and I that's very important, that future performance can be benchmarked against past performance, and we don't lose that kind of golden thread that we've had since 2004-05. But yeah, I mean, there's a lot of people who'd rather that golden thread did disappear, because performance has been appalling and the target hasn't been met since July 2015. So yeah,
not just the golden thread, but if you can measure it, then people will go to measure it, won't they?
Yeah.
James,
Sure.
I'm glad you brought that up, because obviously the cynic suggests that you get rid of the 4-hour target because you don't meet the target, and therefore you can stop talking about the fact that we're no longer meeting the target. But with Simon Stevens signed up, what benefits are they looking to get out of changing this? Are they trying to improve how quickly the super sick are seen, or just trying to persuade people not to go to their GPs and not A&E because they'll be left waiting for too long? Because we talk a lot about targets, but what are they trying to help patients with through changing this?
That's a very good question. So broadly speaking, the 4-hour target has got various drawbacks, in that there's this spike at 3 hour 55 where a lot of patients get dealt with, and then if they are breaches, then it doesn't matter whether they've waited 4 hours and 1 minute or 9 or 10 hours. They're still a breach. So there's a concern that it sort of incentivizes care at certain points in the system. But the people who want to change the target would argue that there's very good reasons clinically for changing the target, but also operationally as well. The way the whole system works goes back to the 4-hour target at the moment, and there's a lot of people who think that isn't the right way to be running the system, and that a lot of other things need to be considered instead.
And one of the interesting things will be how this plays out in local systems and organisations as there is as proposed a phased move to a new setup. And we published a story on earlier this week, or towards the end of last week, that Lawrence Yu wrote about Greater Manchester, and the fact that one of their senior directors in the system in Greater Manchester was talking about how they need to try and now get to grips with their A&E performance after a history of not getting to grips with it in recent months and years. Could you tell us more about that?
Yeah, so Greater Manchester will be one area that will be very keen to sort of have a new target or series of targets, because that would kind of give them a chance to start on a clean slate, because they've really been haunted by their failure on the 4-hour target over the last 4 years since their devolution project launched. Just as for some context, they had 450 million quid of transformation money that no other area got. So there was a kind of reasonable expectation that performance would be better in GM than in other places. And surprisingly, they have lagged behind the national average and the average for the North and Lancashire and Cheshire and Merseyside for the last 4 years. John Rouse, the chief officer who left the devolution team last month, was critical of the fact that regulators, he said, paid too much attention to the A&E target and not enough on the kind of population health and prevention programs that they've been really focused on and spending money on. But there was. That obviously got kind of quite a lot of interesting comment, but then there's an interesting change in tone in this interview that I did with Warren Heppelet, who's the strategy director for the devolution team, who kind of stressed that the A&E problems really need to be dealt with now and deeply understood, and kind of really stressed the commitment to doing this. And I suppose the reason for that, perhaps he thought that John Rouse went a bit too far in distancing themselves from the A&E pathway, or there's a bit more pressure from the regional directorate that they really need to start nailing A&E. But it'd be interesting to see what kind of change in focus there is now there.
Yeah, because in a sense, part of the justification for the A&E target, the review of the A&E target, has been to try and shift the focus of the NHS as a whole onto other things, as Greater Manchester has kind of been seeking to do. But can I ask you a kind of a difficult question as well about what does he have a sense of what they need to do to improve, or do you have a sense of what they need to do to improve?
I think that piece of work is still being done. I have just got a Freedom of Information request back, actually, of lots of analysis of the issues in each of the 10 boroughs, which I'm due to go through in the next couple of weeks. But there was also an interesting comment from Andrew Foster, the recently departed chief exec at the Wigan Acute Trust, who said that basically he thought from the central devolution team there had been too much of a kind of directive and instructive approach, telling trusts what they should be doing, when people in the trusts felt like, well, hang on, we're the people on the front line have been doing this for years. What do you know? And he thinks there should be a much more kind of supportive approach from the devolution team to help kind of analyse demand trends and things like this to kind of give indications for the type of thing that they might they might change.
Sort of enabling. I know there's been a massive amount of discussion about acute service reconfiguration in Greater Manchester for a while now, and some of the commenters anonymously on HSJ as well, I think, hinted at that sort of stuff, that there were big structural problems there. But perhaps one for another time, Sharon.
I think that story also speaks to the issue that is generally being faced by systems trying to work out how to balance prevention and population health with trying to meet the immediate needs of people in the here and the now. Because typically prevention and health management policies like that take years to start showing a benefit. So if John Rouse had wanted to hang around for longer, maybe his prevention strategies would have stopped people coming into A&E maybe 2 or 3 years down the line. But obviously that highlights the problem all systems are facing. You can't stop doing the now to help with the future, and you can't not do the future either. So I can see both sides of that issue, but clearly having people, not meeting the A&E target for so long is not helping keeping people healthy in the here and now either.
Yeah, and that was one of the points that Warren Hepplett made, was that when they started the project, they thought their prevention and population health initiatives would have a much quicker impact on operational performance, and that is one of the lessons they've learned, and that other areas around the country should learn before they go and make these investments.
Okay, but before we move on to the final topic, James, I wondered if you could give us a quick sense of the next steps for this, for the clinical standards review changes to A&E targets, especially now it's colliding with the coronavirus.
Yeah, I mean that could be quite influential to the timeline. So we will get the recommendations this month. NHS England told me this week. I guess they could be delayed, but let's go on the basis that they make the recommendations. The rollout, Amanda Pritchard was saying not that long ago that it was going to be a staged rollout anyway. So there'll be a tension whereby system leaders want to push that rollout as quickly as possible, sort of rip the plaster off. But NHS providers who, as I say, they're signed up to the direction of travel, but they're saying, we need resource to do this, we'll need new IT systems, we'll need more staff, and we don't want it to lead to a deterioration in performance, even though that performance is already pretty. In fact, on the contrary, they want to see a recovery plan. They want to see how this fits into better serving patients, which at the moment, we know how poorly the system's performing in terms of the access targets. So, I mean, Chris Hopson was talking about 2 years to roll out. I doubt that will have, I would have thought people at the centre would want to do it far quicker than that, but it will be, and then, of course, coronavirus. If the whole system's in disarray over the next few months or however long, then you would assume it would be sensible not to start rolling out new performance measures when the system's just overheated.
Yeah,
so, I think that's especially true because people have pointed out that it's very all right, well and good to say we'll cancel electives over the 3-week or the 9-week period, but if you keep pushing back elective surgery, they end up rocking up in A&E with need an emergency admission. So the system could already be facing a pressure from coronavirus, which will knock on to A&E departments and with the pressure they've got under there. So I completely see the chaos they may be facing if they try to change now.
Yeah, there's a kind of interesting question with these big change things in the NHS, targets, finances, the efforts to recruit people, nurses in particular, and build things, and negotiations around the budget and so on, whether coronavirus is kind of a big spanner in the works and delaying factor, or whether people can actually use it to get stuff done under the radar and move things in a more in a more frictionless way than they sometimes can, which will play out over the next few weeks. But and finally for this week, focusing on that financial area, just a few minutes, Lawrence, but to tell us about an exclusive interview we've had with a relatively new Comptroller General.
Yes, a guy called Gareth Davies. Typically the NAO are very kind of understated in their criticisms and work in raised eyebrows rather than colourful phrases. And so this interview felt pretty significant in that when talking about the system of loans for struggling trusts, and then big incentive payments that have been made to trusts in a stronger financial position, Gareth Davies essentially called this unacceptable and a seriously bad way of managing the NHS finances, which is about as colourful as you can imagine the NAO ever getting. It's basically what many commentators have said for several years, but coming from the NAO, it does feel like a kind of heavy indictment of the system that was brought in 2016 by the Treasury and the Department of Health. He obviously thought hard about what he was going to say beforehand, and so was kind of reluctant to expand too much. But for me, the implication was that the last 4 years have, to a great extent, been wasted because they focused too much on trying to improve the headline reported deficit of the NHS in order to prevent the Department of Health from breaching its annual budget, which encouraged short-term kind of firefighting from local leaders, as opposed to efforts to address underlying and structural problems. To be fair to the departments and the NHS leaders, they do seem to have taken these criticisms into account, and the new financial system doesn't sort of hand so much money to trusts that are in strong positions. It will convert the loans into a type of equity, so they won't have to be paid back. And trusts have been given a kind of longer period with which to recover their finances. We'll have to see whether that plays out as a real positive. Because there will still be that annual requirement to try and to hit the RDEL basically at the Department of Health level, but it's progress. And
that's backward looking. 1 minute on how the finances are appear to be stacking up now this financial year and next financial year.
Yeah, inevitably the Q3 numbers from local trusts have gone into the regulators. And this is the point in the year when quite a lot of organisations stick their hand up and say, sorry, we've missed our financial target, because they agreed to a control total at the start of the year that they shouldn't have agreed to. One kind of big example that we've reported this week was South Tees, which have all sorts of underlying financial problems and a big PFI that costs them a lot. Doesn't change the fact that they're going to miss their control total by 20 million, the figure that they said they were going to meet.
Brilliant. All right, thank you. We look forward to receiving those Q3 numbers from the centre or locally as soon as possible. And thank you for listening this week. We'll be back next week. If you're listening on the web, on SoundCloud or something like that, then please do look us up, HSJ Health Check, on Spotify, Apple Podcasts, or your sort of vanilla RSS podcast reader, and subscribe so you can get us direct to your app next time. And thank you for tuning in. See you next week.